MD residents are there. And we have the nuclear medicine physicists for technical manpower, 4 numbers. Academic programs introduced till date as PhD nuclear medicine, which was introduced in December 2019. MD nuclear medicine, July 2020. At the moment, we have 2 MD students which have joined, so 2 seats every session is the limit we have as of now. The procedures what we have introduced. Sorry. The procedures what we have introduced till now is on 27 January 2020. We have introduced 27 gamma scan procedures. And on 3rd June 2020, we introduced additional 6 gamma scan procedures along with the 3 therapeutic procedures. This is a list of procedures introduced. You can see here the 27 procedures and another 6 diagnostic procedures on 3rd June, followed along with the therapeutic procedures. The therapeutic procedures are basically low-dose radiation therapy for differentiated thyroid cancer, radiation therapy for thyroid toxicosis, and bone pain palliation therapy with summary 153. This is therapeutic procedures are limited to only low dose because of we do not have the facility of high dose therapy ward, but these procedures can be done on outpatient basis. The high dose therapy ward is under planning, and we hope it will be ready by another 1 to 2 years. The patient statistics, what we have done till now is around 554 cases. The diagnostic procedures, we have types of scans done are 16, and the pediatric population catered were around 150 out of these 454 cases. 554. Therapeutic procedures started late, so we have very few cases. We have done 7 patients. We have given radiation therapy for thyroid toxicosis and 2 patients for low dose radionuclide therapy for DTC, that is differentiated thyroid cancer. The trend of cases here, this graph represents January. We could, in the 1 week of January, we could do 20 cases, followed by February. We picked up very well, and we could do 127 cases in February, followed by, we had a less number in March because of the COVID pandemic and the lockdown, nationwide lockdown imposed by the government. So March end and the April and the May, we could not do much cases because the isotope supply was suspended from the vendor. When the lockdown opened up, partially we could start the cases, and in June we could do 44 cases, July 57, followed by in August 54. We are picking up slowly, and then till date, this is 4th November, till 4th November we have done 11 cases. On an average, we are doing around 30 cases per week. That is what is the trend going on right now. The various scans, this is statistics which shows the various scans done in the department. Here, bone scan is the maximum requisitions we have got, and we have done around 210, around 40% scans are the bone scans, followed by renal scans, which includes DTPA, EC scan, and the DMSS scan. That is another 40%. So around 80% scans are for the renal function assessment and the bone scans. Remaining, we have the cases where we have done around 1 to 10 cases for the different other scans. The referral patterns, what we have been seeing. Urology, we could get around 160 cases, that is around 20%. And then pediatric surgery, 100 cases, surgical oncology and radiotherapy, we have around 56 cases, that is 10% around. So most of the, like 70% of the cases we have been getting from urology, pediatric surgery, surgical oncology and radiotherapy. Radiotherapy and oncology is basically for the metastatic survey, bone metastatic workup. In urology and pediatric surgery, mostly we have got the cases for renal scans. And also the endocrinology, we have got the patient for thyroid scan. The future plan for the department is introduction of PET-CT, the commissioning of PET-CT imaging, which should, as I told, by the end of this month we will be doing it. We are waiting ARB approval. High-dose therapy facility, expect to start somewhere in the end of 2021. In vitro nuclear medicine facility, which will allow us to do various in vitro procedures. It will be useful for basic science research as well. That we hope to start in 2021. Academic programs. In 2021, we are hopeful to start the postdoctoral certificate course in hybrid imaging, DM therapeutic nuclear medicine, and MSc nuclear medicine. Now I hand over the presentation to Dr. Arun, my colleague, who will be discussing about the scans being done and the basic indications and the procedure protocols.
Good morning, everyone. Thank you, sir. So we are going to see the different scan procedures which are done in our department with few representative cases. There will be a short history and the indications for each and every scan. So starting with the most common scan done in our department, the bone scan. The tracer which we use is the technetium 999 MDP. We all know about the metastatic workup for skeletal metastasis, bone scan is being done. However, there are multiple non-oncological indications. Like for example, for a case of osteomyelitis or any inflammatory arthritis, CRPS, metabolic bone diseases, for even other disorders like stress fracture, undiagnosed fractures, TMJ disorders, and other prosthesis, these indications are also applicable for a bone scan. So this is a case of a T2N1 MXCA breast. The patient came for baseline staging, and this is an example of a normal bone scan. These are the left images is the anterior, and the right one is the posterior static images. These are the planar bone scan images. This is another case of prostate cancer with PSA levels of 60. We can see the multiple dots, black dots in the vertebrae and in few ribs. So this is suggestive of a metastatic disease here and here. So next, unlike bone scan, renogram is done with two tracers. Renogram is also the renal dynamic scan or the diuretic renography, renal scan. There are multiple names, and DTPA and EC are the two tracers which are used to do renal scan. The major difference is DTPA is used for GFR estimation. The only indication, for example, in cases of chemotherapy, before and after chemotherapy, if you want to evaluate the absolute renal function, GFR estimation can be done with the help of DTPA. Actual method, the best accurate method for GFR estimation is the in vitro methods. As sir has explained, we are in the process of getting the in vitro method. However, for time being, we can use the gamma camera scan for GFR estimation. In EC renal scan, we get an effective renal plasma flow instead of GFR, which since it is a tubular agent. For example, in high creatinine patient, DTPA is protein bound and it will not get a good image, or it is not clear. The images are not good. However, EC renogram can be done. In pediatric population, the EC is the agent of choice since it gets a very good image and background. The curves and images are inferior in DTPA, whereas in EC it is best for almost all purposes, except for purposes of GFR estimation. For example, in a patient of voluntary kidney donation, the donor GFR estimation, or for specific purposes of GFR, we can do DTPA. Rest EC renal scan is much better for the rest of the indications. So what are the indications for diuretic renography? The major indication is an obstructive uropathy. To either it might be a pelviureteric junction or a vesicoureteric junction obstruction. The flow pattern in the renal curves can depict what type of obstruction is there, and this is also used to estimate the relative function between the kidneys for pre-op evaluation, whether the kidney is functioning or not. And for renal failure in CKD patients, we can see the relative functions. Other indications are also there for renal scan. The other is being renovascular hypertension, which is also called as captopril renography, where we do baseline and post-captopril studies to differentiate, to find out the causes of whether there is renal artery stenosis or not. Renal transplant, for example, rejection of a renal transplant can be evaluated with the help of renal dynamic scintigraphy. This is a patient having a right hydroureter nephrosis. They want to see whether there is obstruction or not. And we can see this, this is a normal renogram curve. This is uptake and the excretion of the tracer. Both the kidneys are absolutely normal, have equal percentage function. As we can see, initially the bladder is not seen and the bladder keeps on increasing with time. So this is an example of a normal dynamic renal scan. How a PUGIS looks like. This patient had a left, in CT and ultrasound, it showed left hydronephrosis and suspicious for obstruction. The patient had left flank pain. And when renal dynamic scan was done, we can see the left kidney uptake keeps on increasing with time. Even in the delayed images, as we can see, it is keeping on increasing. It is suggestive of an obstructive pattern, whereas the right kidney is absolutely normal. It takes up the tracer and excretes out. So one more image. This is this patient had a right CKD patient with a right renal right HDN, and the patient had some gross hydronephrosis on the right side. They want to evaluate the function of right kidney. As we can see, it is very minimally seen here, and it's around 10%. The function of right kidney is around 10%. This is an example for a straight renal function estimation. Next is the renal cortical scintigraphy. Renal cortical scintigraphy, also called as DMSA scan. The tracer, as I said, it is used, DMSA, technetium 99mm DMSA is used. The major indication being in UTI, whether the infection is in the kidney, the pyelonephritis, or in the lower urinary tract infection, it can differentiate. The pyelonephritic focus will be photopenic in the cortical scintigraphy if there are some abscess collection, and DMSA is considered one of the best modalities for split renal function. It is better than other tracers, and since it binds only to the cortex, the absolute percentages of split renal function can be obtained. Next, another important indication is to see for scars after an infection. We'll see in the image. Like this patient is a case of recurrent UTI, and to find out here, these are the anterior images, posterior images, and the lower rows are the oblique images. This left kidney, as we can see here, has very minimal patches of tear shape. Like hardly we can see the left kidney. It is almost non-functional left kidney. In right kidney also, we can see a wedge-shaped cortical outline defect. This is a normal cortical outline. However, we can see there's a cortical defect here, which is seen in all the images. This is an example of an upper pole scar. Next is the thyroid scan. It is one of the most commonly performed scans in the department, and it is done with technetium 99mm per technete. The major indication for thyroid scan is to differentiate between the various causes of hyperthyroidism. Sometimes the patient might present with similar symptoms of hyperthyroidism. To differentiate between the Graves' disease as well as the other causes of hyperthyroidism like thyroiditis, thyroid scan can be used. Other indications are to locate the ectopic thyroid tissue, to see the functional status of nodules. For example, in case of a toxic adenoma, we want to see the functioning pattern of the nodule, or if there are some cold nodules in a multinodular goiter, if you want to see the individual functions of various nodules, thyroid scan can be used. The thyroid scan can also be used for evaluation of a congenital hypothyroidism and dysharmogenesis workup. So the normal thyroid scintigraphy, as we can see, this is these are the anterior images and the oblique images. And we can see the gland uptake is normal, whereas there is some salivary gland uptake in the rest of the scan. So to find out how to differentiate between Graves and thyroiditis, here we can see the Graves disease has only the gland showing uptake. Nothing else is seen in the scan, which means that the gland is hyperfunctioning and is taking up the uptake. Whereas in the thyroiditis, it is the reverse. We cannot see the thyroid here, whereas the rest of the gland is seen. This is because the destruction of the thyroid gland, there is the tracer doesn't go into the gland because of the destruction and release of hormones in thyroiditis. There is no thyroid uptake seen. Whereas in Graves' disease, due to hyperfunctioning of the gland, all the tracer is going only into the gland and not into the rest of the body. So this striking difference will help us differentiate between the various causes of hyperthyroidism. Next is the parathyroid scintigraphy. It is done with technetium 99mm sesame B. The major indication is to localize and lateralize the parathyroid adenomas and hyperplasia. any case of hyperparathyroidism, the adenomas can be located. It can help in focused parathyroid surgery. For example, next I'm going to show a case of MEN syndrome. This is a case of MEN 1. Patient had a right parathyroid adenoma and excision was done. Patient also had insulinoma and enucleation was done. Now the PTH levels are rising and it is 195. So the patient was evaluated with ultrasound also, and we have the patient suspected parathyroid adenoma. This is the early anterior image of the system. Maybe we can see the heart uptake here slightly, and this is some normal thyroid uptake seen in the system. Maybe these are the late anterior images. Usually in the late images, the thyroid uptake diffuses out and only the parathyroid adenoma is visible. Here we can see some extension in the left lobe of near in the lower part of the left lobe of thyroid. However, it is not clear even in the late images. So what we did is we did a thyroid scan for this patient. This is the thyroid scan. We did a thyroid scan and superimposed on the parathyroid scan here and subtracted it. On subtraction, we can see a nice nodule here in the left lower part of the gland. So we did a SPECT CT. SPECT CT is basically a 3D representation. Like X-ray and is a 2D and CT is 3D. This SPECT is a 3D part of the 2D planar scan. So here we can see the nodule here, and it correlated well on the CT images. It's a very small, few millimeter sized parathyroid adenoma. Finally, the impression was a left lower parathyroid adenoma. To the next, this is a hepatobiliary scintigraphy, also called as HIDA scan. It is done with technetium 99M mebrofenin. The major indications are for biliary system patency in pediatric population to differentiate between the biliary atresia and other causes of neonatal hepatitis. It is also used in assessment of biliary enteric bypass, like after post procedures, we can see the patency of the biliary system. And it can be also used to diagnose bile leakage. Initially, HIDA was used for acute cholecystitis for evaluation. However, with the advent of ultrasound, the indication has diminished. So this is a case referred from the Department of Surgery. The patient had a fall and trauma and had some pain in the right upper quadrant. So patient was diagnosed to have hematoma, subdiaphragmatic hematoma, and the pigtail catheter was inserted, and they found a bilious secretion full of bile. It was not, they couldn't, MR cholangiography and CT were done, and in order to localize the site they were suspecting bile leak, and in order to localize the site of bile leak, technetium 99M HIDA was done. These are the early images, anterior image, this is the posterior image. We took the images up to 24 hours. Here we can see a focus of dot-like uptake in the anterior images with the normal hepatic uptake in the segment 7 and 8 is not seen here. In the posterior image, you can see there is a tracer leaking into the photopenic area. With time, the tracer concentration is increasing. As we can see, the rest of the uptake is going to the bowel. The rest of the liver is showing minimal uptake. This uptake keeps on increasing with time. At 24 hours, there is hardly any liver uptake. However, the collection is seen. So we did the SPECT CT at the right time initially. We can see that the location of the bile. Here we can see the distended duct here, and this is the collection which was there. Initially, there was no uptake where we could find out to pinpoint the localization of the leak, and with time, we can see that the collection is happening in the segment 7 of liver. We can even see the pigtail catheter here. So another indication for scanning in brain tumor is for brain tumor can be imaged with the help of technetium 99M GHA. This brain SPECT imaging has a major indication, only one indication, that is to differentiate between the radiation necrosis and the recurrence. The radiation necrosis and recurrence might appear similar on MRI. For example, after glioma patient might have post-radiation necrosis. It can be hard to differentiate with the recurrence. So this is a patient of glioma, frontal glioma, left frontal, and the patient was operated. And after 3 months, the patient underwent an MRI, and they had the doubt whether the patient has post-radiation necrosis or a recurrence. Here, these are the SPECT images. The upper rows are the CT images, the middle are the SPECT images, and the lower images are the fusion or the hybrid images. We can see in the left frontal region, there is a intense uptake. Here in CT, we can see the edema. However, the uptake is so intense, like GHA uptake is only seen whenever there is a break in the blood-brain barrier. So this, finally, this is a case of recurrence of the left frontal brain. The other indications in nuclear neurology are for epilepsy and movement disorders. For example, we have perfusion imaging, the ictal and interictal imaging to differentiate to localize the epilepsy, and movement disorders in order to evaluate Parkinson disease to differentiate between Parkinson and Parkinson mimics. Alzheimer's disease versus DLB can also be differentiated with the help of Trodat scan. Epilepsy can be done with the help of technetium magninum in ECG study. Coming to nuclear cardiology, there are three main studies. We'll discuss about that. The myocardial perfusion study, stress rest imaging, and the myocardial viability study. Basically, it is just a rest study of the whole part. These indications are based on the appropriate use criteria to detect the symptomatic coronary artery disease. It is the myocardial perfusion study is basically a risk assessment study for majority of the indications. Like, for example, in a patient with a chronic stable coronary artery disease with suspected with having symptoms, for preoperative evaluation of at-risk patients with after a coronary syndrome, the patient might to take a decision regarding revascularization. This stress rest study provides us the information for inducible ischemia. Inducible ischemia is whether during the stress there will be lesser perfusion, and during rest the perfusion restores, which means that the myocardium is under ischemia. Whereas the rest only study or viability study is done after and there will be whether to find out whether the myocardium is viable or not, or whether the only scar is there. So that is the indication for viability. So we'll see a case about the post revascularization. This patient had old coronary event, and patient was underwent CABG, Lima to LAD was done, and patient now has symptoms on exertion, and the patient was referred for a stress rest myocardial perfusion study. The upper rows are the stress images and the lower rows are the rest images. This is the axial images where this is the inferior part, the inferior lateral wall. We can see there is some there is no uptake here, whereas in the rest images the uptake is returning back. Similar in the lateral wall, this horizontal long axis and vertical long axis images. Here, this is the lateral wall, this is septum and the lateral wall. In lateral wall, in the stress images, we can see very minimal uptake here. However, in rest, we can see the uptake is coming back, which means that these two areas are having inducible ischemia. There are other nuclear cardiology procedures like multi-gated acquisition. This is study basically to find out the ejection fraction. This is an absolute quantification with of ejection fraction. With it is an objective study with no difference in ROA or any other changes. It's mainly used in evaluation of LV function. For example, in case of cardiotoxic chemo, we can find out the baseline as well as the post chemo difference. In order to find out ejection fraction in congestive heart failure, Mugar study can be used. This is one of the rarely performed studies in our department. It's a lymphoscintigraphy, which is done with technetium sulfur chloride. As it is a functional study, we inject the tracer into the dermal spaces and it tracks along the lymphatic channels throughout the body. The main indication is to differentiate between lymphedema and other causes of edema, primary and secondary lymphatic dysplasia in pediatric and adult population, and secondary chylous leakage and chylothorax. After trauma or any surgery, there might be some chyle leakage, which can also be picked up by lymphoscintigraphy. So now, this is a case of left limb swelling, and they want to find whether there is some lymphedema or not. It's an example of a normal study. These two are the tracers which was injected in the leg, in the fingers, and we can see nicely the lymph nodes here in the iliac and the iliac region. Next is the gastroesophageal reflex study. This is also known as milk scan. It is done with the help of technetium 99 sulfur chloride. As the name suggests, it is used for evaluation of the gastroesophageal reflex. For example, in pediatric population who are unable to change in pediatric population who are unable to report the symptoms can be used. This is a child having symptoms of difficulty in reflux. They want to find whether there is a gastroesophageal reflux or not. Here we can, these are the dynamic images taken and which was done as a video format. This is the normal stomach, which we can see the tracer is going through the intestine. If there is some reflux, the esophagus will be seen as spikes of uptake. Here, this is a case of a normal study. There is no GER reflex. In 123, till now we have seen about the scans based on technetium 99M tracer. However, now this is a MIBG, it is based on iodine 131. This iodine 131 MIBG is a mimic of noradrenaline, and it can be used in indications for of neuroendocrine tumors like pheochromocytomas, paragangliomas, medullary thyroid cancer, carcinoid, and other different type of neural tumors, neurotrust origin tumors. It can also be used for sympathetic innervation of myocardium. For example, after MI or any cardiac conduction abnormalities, innervation of myocardium can be evaluated. Surprisingly, MIBG scan can be also used for Parkinson's disease and movement disorder evaluation. This is because the autonomic dysfunction of movement disorder starts earlier before the patient becomes symptomatic, and normally MIBG is seen in the cardiac neuronal architecture. There is cardiac uptake normally. However, in movement disorders, the cardiac activity might be lost or reduced, which can be evaluated. So this is a case of kid having neuroblastoma and was on 11 cycles of chemotherapy and was finished in March. This is our anterior images. These are the posterior images. We can see there are multiple black dots studded throughout the body. These are the example of metastatic sites. In SPECT-CT, we can see there are multiple sites. Just for context, the same patient underwent a bone scan before. If this was done in March, this scan was done last month. So there might be a 6-month difference, but in March, there is very subtle lesion in the dorsal-lumbar vertebra. We did a SPECT-CT and we found out there are some sites of metastasis. It's hard to appreciate. However, if we did in the MIBG scan, due to the marrow metastases are not picked up well in the bone scan. In MIBG, most of the metastases can be clearly seen. So just to say that different context of scans for different indications, the patient one scan might show better picture than the other. So after now coming to the therapeutic procedures, there are 3 main therapeutic procedures: the radioiodine therapy for thyrotoxicosis, low dose therapy for differentiated thyroid cancer, and bone pain palliation therapy with samarium. The bone pain palliation therapy can be done for patients who have intractable bone pain, who needs lots of analgesic dosage, and this samarium 153 dose, once injected, the patient might have a long-lasting relief, reduced need for analgesic, etc. And we have done radioiodine therapy for thyrotoxicosis in Graves' disease and toxic adenoma. 7 patients have been done, and they are currently under follow-up. So this another major indication for radioiodine therapy is in thyroid cancer. For thyroid cancer, we need in differentiated thyroid cancer, in low dose radioiodine therapy can be administered based on OPD. As sir already told, if high dose ward is there, we can treat all type of all risks for thyroid cancer. Here we can treat only the remnant and the low dose, because we can give only 30 millicurie. The remnant and lobar ablation can be done. Right? Remnant is the small amount of tissue which is left. It might harbor some micrometastatic disease, so it can be ablated with help of radioiodine. For example, in another lobar ablation is where one hemithyroidectomy is done and the other lobe is free of tumor. If we have cleared with ultrasound and other imaging modalities that the other lobe doesn't have any disease, we can directly ablate the entire lobe, it is called as lobar ablation. So this is a case of papillary carcinoma thyroid. The patient had low to intermediate risk disease and underwent total thyroidectomy. And the patient was kept on follow-up. We did a diagnostic whole body radioiodine scan after proper preparation, and we can see 2 dots of uptake in the thyroid bed. So we did a SPECT-CT to see whether they are lymph nodes or other just thyroid bed. Here the uptake is restricted to the thyroid bed, and it was diagnosed as a remnant disease. So we gave 30 millicurie OPD based therapy for this patient, and we can see the uptake here in the post therapy scan. There are no other uptakes anywhere else in the body, suggestive of no other metastatic site, just a local disease. 6 months later, this patient will again undergo a whole body radioiodine scan, and we can find out whether the remnant was ablated or not. So coming to FDG PET CT, as sir has already told that FDG will be starting by the end of the month or next month. So just to give a brush regarding the indications and of our FDG, most of us know that about the oncological indications, like in most malignancies for diagnosis, staging, restaging, recurrence evaluation, response evaluation to chemo, these major indications for most of the oncological diseases. However, for cardiological disease, like from the cardiology point of view, patient FDG is considered the gold standard for metabolism or viability. If a tissue is showing FDG uptake, it means the tissue is viable. So it can be used to pick up hibernating myocardium. This can be combined with the SPECT imaging of myocardial perfusion study to find out the hibernating myocardium. Other major indication for FDG is in the neurological and neurosurgical part. The brain tumors, apart from brain tumors, movement disorders, dementia, and epilepsy can be all are indications for FDG. To find out localize the FDG for movement disorders like Parkinsonism, differentiating between different type of movement disorders. In case of dementia, to differentiate between Alzheimer's and DLB and Alzheimer's and PSP. Other multiple indications are there because there will be characteristic pattern of uptake in the dementia disorders. One more area of FDG indication will be in inflammation and infection. Like for example, a prosthesis infection or a valve infection, endocarditis, any type of infection and inflammation like SLE or vasculitis can be picked up by FDG because FDG is concentrated in the lymphocytes and macrophages. Whenever there is inflammation, there will be increased uptake at those sites. So these are the major 4 indications for FDG. Thank you. Now I hand over to Dr. Rajesh.
Thank you for your patient listening. Can we have the chat?
Yeah. Now we take questions. So, we have a question from Dr. Ravin. Do we have any specific strategies from nuclear medicine to deal with non-radioiodine avid lesions, particularly children, where we expect good prognosis? Okay. So, majority of the differentiated thyroid carcinomas have radioiodine uptake. The non-radioiodine avid lesions are the number of lesions are very small, and the number of patients and the percentage of patients are small. In pediatric population, usually it is a well-differentiated thyroid cancer, and it will respond very well to radioiodine. Even lung metastasis and all lymph node metastasis can be ablated with the help of radioiodine. However, if there are non-radioiodine concentrating lesions like long-standing disease converting into a poorly differentiated malignancy or anaplastic transformation, then we can go for other imaging modalities to evaluate the sites. However, based on the therapeutic standpoint, we have tyrosine kinase inhibitors, and we don't have. There are some studies showing peptide receptor radionuclide therapy for non-radioiodine lesions. However, if there is no non-radioiodine concentration, there is no further indication for any radioiodine in that patients. I hope this answers the question. Yeah. Next is from Dr. Surinder Devara for technetium versus thallium for myocardial viability assessment. Which is better? Are we going to use thallium for future in our institute? So,
no, thallium, we are not going to use thallium because thallium is not available also, and it's a very costly agent. Now, people are mostly using System EB, the technetium-based tracer, and that is very well, it gives us information, and we have when the PET CT starts, we will be able to do FDG, and that will complement all the information. And FDG is definitely a agent which is basically tells us about the viability of the tissue, and that will be very, very useful for the to detect a viable myocardium. Next is Vijay Madhuri. This says the question is for a unilateral small size kidney with overall normal creatinine, which is better to document function. That is, we can do DMSA scan. DMSA scan will give a good function. With a normal creatinine, no use of document function. Now, just for documenting function, DMSA will be useful. But if we want to know about the clearance and all those things, we can do a renogram study with a DTPA. Sarvesh Tiwari has a question. Do we have TRODAT spec available for PD and available ECD spec for? I would like to mention here, in the list of procedures we have already mentioned, we have the TRODAT scan as well as the ECD scan. So we can, both these procedures can be done in the department at the moment. So we welcome all the cases for these scans. Saurav Singh, is it possible for the nuclear medicine department in near future to develop radionuclide patches for transdermal delivery of cutaneous tumors and for proliferative? Yeah, this is very much possible, and we can do it. For phosphorus 32 has been tried, and the P32 patches have been developed at AIIMS Delhi. So technology is already available, and we will be able to do it. And once we will definitely need your help in developing this, and then we will be able to treat the cases also. Yes, Vijay is asking about the PSMA PET CT and Dr. Knock and Dr. Talk. Yes, once the PET CT comes here, we will be able to do. But we need a gallium generator for that. With that also, we are hopeful within a few months we should be able to have gallium generator, and then we can do a gallium labeled Dr. Knock, Dr. Talk, and all the PSMA scans also. We can do with fluorine 18 also, but we have to procure fluorine 18 and label it here. Some vendors are also providing labeled F18 PSMA. So not many are there, but if possible, we can do F18 PSMA. But Dr. Knock will be requiring the gallium generator for that. Anil Budania is asking, lymphoscintigraphy, is it available here for lymphangioma? Yeah, lymphoscintigraphy is very much available. We have done few cases, but we have done mostly for the detection of chylothorax and identifying the site of lymphatic leak. But we have it here, and we welcome all the cases for lymphoscintigraphy. I think that much questions are there in the chat box.
Can wait for a few minutes.
Any more questions are there? We're still waiting for some more questions. If available, we'll be able to answer. I don't think any more questions are coming up. So we close the session here with our presentation. Thank you for your patient listening, and we welcome you for all kinds of academic discussions and queries, and also for any research collaboration. So anytime anybody can walk in, and we also welcome your residents to drop into the department and have a look at the procedure protocol, and whenever they are sending the scans, they can follow the patient scans also in the department. Thank you very much.
Thank you.